Thanks, Fred. So for this session, what we're going to do is I'm going to give a bit of an overview of just osteobiologics and taking a look at the data that would support a broad spectrum of materials that we use. And then Jeremy Smith is going to come up and talk about some of the DBMs and synthetics more specifically. Joe's going to talk about some specific products with regard to stem cells. And then we'll talk a bit, Matt will talk about autograft and when to use autograft. And I hope we'll have some time left for discussion on this. So I'm going to give more of a broad overview of the evidence for the broad spectrum of things that we use for our bone graft materials. And again, these are my disclosures. But I'm not going to focus on any one product here, but really try and give you a bit of a market overview. When we think about what we do commonly in the cases we've talked about over the course of the last day, between cervical, posterior-based lumbar interbody, anterior and posterior, deformity cases, tumor cases, a broad spectrum of things that we do in terms of surgical approaches, but also a broad spectrum of our bone graft options. And in broad categories, we can call these bone graft extenders, which are essentially our osteoconductive matrices, bone graft enhancers, which is a category that really hasn't been well proven, but things like our, I'm looking for Jim Yu, who has some enthusiasm, I think, for PDGF and platelet-derived factors, but not a lot of good evidence suggests that those are effective for fusion. And our bone graft substitutes, so our recombinant proteins and to some extent our demineralized bone matrices and some cell-based matrices. I think there's almost no area of medicine where there's more variability than the choice of bone graft materials. And I think for any given case, be it an ACDF or a TLIF or an ALIF, the spectrum of things that we may be using is really quite broad. And when we look at the market, this is a bit of an overview that I put together and looking at the market right now, and this is a bit of a change. If you look at 2011, over half of the market was actually BMP. So in a $2 billion market, BMP was at its peak close to $1 billion. And you can see how dramatically that's changed after essentially the publication in the Spine Journal in 2013 of some of the complications associated with BMP and some of the critical aspects of BMP. So you see that the market for BMP has actually dropped by about 50%, and that's been replaced largely by DBMs, by cell-based DBMs. We'll talk a bit about that next. And synthetics now. Synthetics make up fully 30% of the market of bone graft materials. And again, in any given case, many of us use combinations of all of these. But I thought that was an interesting slice of what's really happening out there, and what's growing fastest is synthetics and also some of the cell-based DBMs. And I'll bring into question of whether or not that's really supported by evidence. You know, a lot of times, I showed this slide yesterday, is when we're making informed decisions, how much evidence do we have? And what we'd really like to have is compelling evidence. We'd like to have a level 1 randomized prospective study comparing two things head-to-head. But so often we really don't have that level of evidence. And what we're dealing with is preclinical evidence, we're dealing with case series, we're dealing with incomplete evidence. So sometimes we're looking at, does the material promote cells in a petri dish to produce alkaline phosphatase? Can we produce bone in a submuscular pouch? That would be the assay for osteoinductivity, or looking at posterolateral fusions in a rabbit. There's a progression when we look at evidence, a progression both phylogenetically as well as in terms of just a hierarchy of evidence for what we might look at. And whenever somebody comes to me and says, hey, I want to show you this newest, greatest bone graft material, then the first thing I'll ask is, well, what's the highest level of evidence you've got? Well, I've got a couple of case reports. Eric over in Dallas tried this in a few cases, and you like Eric, and you know what a good guy he is. So he's got a couple of cases with CT scans, and usually that's enough evidence for me. But having said that, you know, what I'll try and get to is what's the highest level of preclinical evidence? Has this been looked at in a rabbit? And then what's the highest level of clinical evidence? And again, what we're sorely lacking is a true level 1 evidence in most of these cases. In broad categories, when we think about what we're trying to put together in bone graft materials, we're trying to put a scaffold together for osteoconductivity. We're trying to put growth factors into this as much as possible, and also have a matrix that's amenable to cells, or in some cases actually that includes cells. And that coming all together is what gives us a useful graft composition. So focusing a little bit on each of these, the cells, we did some interesting work in our lab at UCSF. Actually, Jill Helms was lead on this. And what she looked at is when we put cells in a posterolateral model, what happens to those cells? Are they viable? Do they really contribute to the fusion? And she did a really interesting assay where she took a male mouse. So these are all cells, and I think, Jeff, you were in the lab at this time, or you were at UCSF at the time. Took bone marrow from a male, so all these cells obviously had an X chromosome, or had a Y chromosome, sorry, my genetics are a little off. So they all had Y chromosomes, and then she tracked that Y chromosome by grafting female mice. And essentially what she showed is in this mouse tail fusion model is that the cells that were grafted, these are the cells you can see here on a fish assay with in situ hybridization. You can see that the fluorescence is the cells that she grafted. She's actually tracking the Y chromosome here. So those are all male cells that contribute to the regenerate. And about half of the cells in the regenerate were actually the grafted cells. So that's what gives us some confidence that maybe we can introduce cells and actually promote fusion. There's all sorts of places we can get cells from. We can either fractionate or use unfractionated marrow, and that's what a lot of us do by taking bone marrow aspirate. And there are other sources of cells as well that are available commercially. And one of the reasons that this is such a wild west is that the 361 pathway really has minimal regulation. The regulations here in terms of a legal aspect, I've got a son who's going to go to law school, so one day he'll be able to read things like this to me. But having said that, the legal aspect of this is the tissue has to be minimally manipulated. And otherwise, it has to be proven to be safe, but there's got to be no proof of efficacy that's required at all. So that's why there's so many options out there for what might be used, and so many products that many of you have seen on the market, and some of these will get talked about subsequently, so I'm not going to emphasize this, but cells from amniotic tissue, from fat, from placenta, from the umbilicus. I'm not sure how umbilical tissue is homologous to a posterolateral fusion, but somehow that gets by the lawyers, and the FDA thinks it's fine. So what's the real evidence for cells in our bone graft? And I think a lot of this evidence is limited. What we know is if we put mesenchymal stem cells with bone chips in a submuscular pouch, we can get induction of bone. But that's a pretty low threshold for osteoinductivity. So we did a study actually just up the road here. Some of you locals know where Ogden, Utah is. I'm looking at Brent a little bit. I think that's Utah State University, right? So isn't it? Weber State. No, it wasn't in Ogden. It was Logan. Logan, Utah. So I went up there and actually spent a weekend doing some rat surgeries and some rabbit surgeries as well. And we looked head-to-head at demineralized bone matrices with or without cells. And the issue was at UCSF, people like Frank Fitzgerald is here, but a bunch of people came in and said, hey, how'd you like to have these cell-based cells in your DBM? We've got the ability to add cells, and for twice or three times the price, you can have this yourself. And I said, well, where's the evidence here? Because right now that's going to fit into the category of a DBM rather than anything more special than a DBM. So we did a head-to-head study of how DBMs did compared to cell-based DBMs. And we used both a posterolateral rabbit model as well as the osteoinductive assay. And to bring this to a full circle, it's in press right now. But what we showed is that in general, I thought I had a couple more slides on this, but in general, the cell-based DBMs did actually worse than the DBMs without cells. In terms of why that mechanism might be, it may be that cells actually have an anti-inflammatory effect. It may be that the preparation was different so that to have viable cells in it, the DBM wasn't as active. We're not sure why, but the cell-based DBMs did worse than DBMs alone. Having said that, there is some literature, and I'm not going to go too much into this because another talk's going to cover it, but OsteoCell's got some literature suggesting that in a case series, this does reasonably well in the lumbar spine for an ALIF. There's some literature from Trinity suggesting in the cervical spine, again, cell-based DBMs can work as well as other materials we might use for an ACDF, but it's not a head-to-head control. This position paper that was published in the Spine Journal a couple years ago now, I think is useful, is although cell-based DBMs do appear to be safe, and therefore from a regulatory perspective they're available, the evidence to support cell-based DBMs is really quite poor. And with the current lack of evidence showing that mesenchymal cells in DBM can even survive in a fusion or contribute to a fusion, then the claim of efficacy really can't be made. And that's my position right now on cell-based DBMs. With regard to DBMs alone, I think DBMs are a very effective extender, and I think that's one of my preferred extenders for the posterolateral space. Moving forward to growth factors, I'll just go through this briefly, but with regard to BMPs, you're all familiar with the evidence of BMPs in the anterior interbody space, but pretty much the level of evidence is limited to the anterior interbody space. And of course, the reviews done out of Leeds and out of Oregon suggesting that BMP overall does as well as autograft. Some minor association with increased cancer rates at the higher doses, but at the doses that we're using, really not a big cancer risk either. And overall, the meta-analysis suggests that BMP and autograft were performing very similarly with very similar complication profiles. I factor is something that we've done some work with at UCSF now. Some of you know this is a short-chain peptide that the study that they did wasn't terribly compelling. Paul Arnold was the lead on this, and they took allograft cervical wedges or cervical allograft in ACDFs and compared basically bone shavings to I factor. And essentially what they showed is that I factor and bone shavings were similar. So I actually had some opportunity to comment on that study design, and it was troublesome to me because if you're the same as something that costs me nothing, then why would I pay something more than nothing? So having said that, the market is growing for this a bit. I can't explain the marketplace, but I can give you some science, but I can't explain the market. And then finally, I'll just talk about matrices. And with regard to the synthetic market now, that comprises 30% of the bone graft market. So again, a $2 billion market, 30% of which is synthetics. And I think that this is a paper I wrote about some years ago with David Bradford. And what we summarize here is that the idea is that synthetic matrices essentially are mimicking the inorganic phase of bone. So with demineralization of bone, we're getting the organic phase, we're getting osteoid. With synthetics, we're mimicking the inorganic phase, so we're creating an osteoconductive matrix. And with different preparations, we can affect the resorption rate, we could affect cell adherence and osteoconductivity, in some cases even osteoactivation. Again, in this review by Tom Morose, looking at some of the common bone graft extenders, the suggestion here was that calcium phosphate with DBM was perhaps most supported by the literature. And then we wrote a paper looking at synthetics with cells, suggesting that cells and synthetics can perform as well as autograft in a review of the literature. So summarizing here, I think when we think about what should we be using for our bone graft materials, we really need to look at the evidence for what's supported by literature and what's not. I think the best evidence certainly is for BMP, and in part that's because from a regulatory perspective, BMP was approved as a device. I-Factor's got some evidence, but unfortunately the evidence is that it's as good as something that's free. The other materials that we're using, DBMs and synthetics, the regulatory pathways aren't as demanding, and therefore the level of proof really isn't as high. And the question becomes, when do we need rocket fuel, or when do we need something that's a little bit simpler and also cheaper? We need to pay attention to clinical evidence, cost, as well as the complication profile. So I ride to work most days on a bicycle that looks something like the one here on the right, and I've got a partner who lives a similar distance from the workplace as I do, who drives a car that looks something like the one in the middle. So, you know, when do you need a car like that versus when is the bike adequate? And I put together this, and this was from a publication in the Spine Journal some years ago, suggesting that we want to look at the biology as well as the demand of the space. So in something that's got good biology, a small space requirement, an ACDF, for example, that's a pretty minimal requirement for your bone graft material. In contrast, when we've got a big space, like somebody who's already got established pseudoarthrosis, maybe somebody who's already been exposed to a prior surgery, non-union, and a big long fusion posterolaterally can be under tension. That's a more challenging environment. And what I'd suggest is that with good biology, with smaller defects, we could do well with our osteoconductive matrices. Our osteogenic and inductive matrices may be more appropriate for the more demanding scenarios. So my conclusions then with this overview is that there's a lot of variability on choice for bone graft substitutes in really common applications, and decision making is oftentimes made with incomplete data. I think policy of asking for the highest level of data available gives us the ability to make some comparisons and to be a bit more informed in our choices or in terms of making changes in what we choose to do. I think matching bone graft choices with patient needs is important and being aware of the costs and complications. And I think what we really need in this field is a registry where we can actually look at the incremental cost effectiveness and compare different products in a head-to-head fashion and ultimately find a solution that's cost effective. So again, thanks for the opportunity to start this program. And I think with that, I'll invite up our next speaker. Jeremy is going to talk more specifically about some of the DBMs and synthetics. Yeah.